नमस्ते बिटिया, हमेशा खुश रहो बिटिया। A very good morning to you all. Myself, JAIN Dr. Ravi Jain, Assistant Professor, Department of Practice of Medicine, Faculty of Homeopathic Science in JAYOTI University. In this series of water and electrolyte imbalances, today we are going to discuss the disorders of potassium metabolism. Initial slides are kept the same so that if anyone has not seen the disturbance of the sodium metabolism, then he or she will not face any kind of problem in understanding disorders of potassium metabolism. Water consists of 60% body weight. Fat contains less water. Obese have less body water. The water in the body is distributed into two major compartments, that is intracellular fluid compartment, intracellular fluid and extracellular fluid. Intracellular fluid consists of 66% and extracellular fluid consists of 54%. Extracellular fluid is further divided into interstitial fluid, that is 65%, intravascular fluid, that is 25%, and transcellular fluid, that is 10%. In the intravascular compartment, only 10% is in arterial system and 55% is in capillary system and 35% in the venous system. This figure shows the body fluid distribution. The total body weight in male, it consists of 60% fluids and 40% solid. Out of 60% fluid, 2/3 consist of intracellular fluid or ICF and 1/3 consists of extracellular fluid or ECF. Out of this extracellular fluid, 75% is interstitial fluid and 25% is plasma. So again we study this. Body fluids are distributed into two distinct areas: intracellular fluid ICF, which consists of 40% body weight, extracellular fluid, which consists of 20% body weight, interstitial fluid that consists of 15% body weight, plasma with 5% body weight. Fluid compartments are separated by membranes that are freely permeable to water. Movement of fluid through the hydrostatic pressure and osmotic pressure. The composition of fluid in intra and extracellular compartments are entirely different. Extracellular fluid is present outside the cell and intracellular fluid is present inside the cell. In the extracellular fluid, the protein content is less, whereas in the intracellular fluid, the protein content is more. The major cation in extracellular fluid consists mainly of sodium, potassium, and calcium, whereas the major cation in intracellular fluid consists mainly of potassium and in some extent magnesium. The major anion in extracellular fluid consists of chloride ion, and the major anion in case of intracellular fluid consists of phosphate ion. What is the requirement of conducting biochemical laboratory investigation in case of any disturbances or electrolytes? Number one, to screen out an asymptomatic subject. You have to screen out a subject who is not having any symptom, but there are disturbance of electrolytes. To assist in the diagnosis of a patient's presenting complaint. To monitor changes in test result as a marker of disease progression or response to the treatment. In today's lecture, we are going to discuss about potassium metabolism. Potassium is the major intracellular cation. It plays an important part in generating the resting membrane potential and allowing the propagation of the action potential, which is crucial to normal functioning of nerve, muscle, and cardiac tissues. Aldosterone is an important factor in the acute and chronic adjustment of potassium secretion. The disorders of potassium metabolism can be divided into hyperkalemia, where there is excess of potassium, hypokalemia, where there is deficiency of potassium. The normal range of potassium is 3.3 to 4.7 millimole per liter. Now we will start with hypokalemia, that is deficiency of potassium. What are the different causes of hypokalemia? The causes includes decreased intake and excessive production of potassium, excessive potassium loss. So there is decreased intake of potassium ion and excessive loss of potassium. Gastrointestinal causes includes inadequate dietary intake, gastrointestinal fluid loss, which includes prolonged vomiting, diarrhea, fistula, mucus secreting adenomas, mucosigmoid anastomosis, and paralytic ileus. In renal losses, there are diuretics, thiazide loop diuretic or osmotic diuretics that causes metabolic alkalosis. Excessive cortisol causing aldosteronism, primary or secondary. Cushing's syndrome, renal tubular disorders, renal tubular acidosis, leukemia, antibiotics, and magnesium depletion. Due to the shift of cells, hypokalemic period paralysis, alkalosis, and incident defect. Clinical features of hypokalemia includes muscular weaknesses, tetany, fatigability, thirst, polyuria, paralytic ileus, and cardiac arrhythmias. The investigations that could be done in the cases of hypokalemia includes investigation and management. Both are discussed here. Measurement of plasma electrolytes, bicarbonates, urine, potassium, and sometimes the plasma calcium and magnesium could be done. The measurement can be done to assess about hypokalemia. Plasma renin activity is low in the patient with primary hyperaldosteronism. Measurement of urine chloride concentration. A low urine chloride less than 30 millimole per liter is characteristic of vomiting, while a urine chloride greater than 40 millimole per liter suggests of diuretic therapy. Now the investigations that could be done also includes ECG changes. There are ST segmental depressions and appearance of Q wave. Severe hypokalemia produces premature ventricular and arterial contractions and tachyarrhythmias. The management consists of treatment of the cause. Oral potassium 20 to 100 milliequivalent per day, for which fruit juices, coconut water, or intravenous saline as intravenous fluid are administered. Care of the patient with impaired renal functions, avoid hyperkalemia. Potassium-sparing diuretics such as spironolactone. If magnesium depletion is also present, replacement of the magnesium may be necessary to allow correction of hyperkalemia. Now we start with hyperkalemia, that is excess of potassium in the body. Hyperkalemia can be dangerous because of the risk of cardiac arrest caused by the marked slowing action, potential conduction in the presence of potassium levels above 7 millimole per liter. What are the different causes of hyperkalemia? Inadequate excretion, that is caused in renal failure, acute or tubular disorders, adrenal insufficiency, Addison's disease, hypoaldosteronism, potassium-sparing diuretics, shift of potassium from tissues that occurs in acidosis, metabolic or respiratory, tissue injury, muscle damage, hemolysis or internal bleeding, hyperosmolarity, insulin deficiency, hyperkalemic periodic paralysis, or excessive intake of potassium with impaired renal function. The clinical feature includes patient typically presents with progressive muscular weakness, but sometimes there are no symptoms until cardiac arrest occurs. Generalized weakness of the skeletal muscles. The investigation consists of serum potassium level greater than 5.0 milliequivalent per liter. Typical ECG changes shows peaking of the T wave, widening of the QRS complex, prolonged PR interval, disappearance of the P wave, nodal and ventricular arrhythmias. QRS complex merges with the T wave in a sine wave pattern with ventricular asystole or fibrillation. The management consists of treatment depends on the severity and the rate of development. The absence of neuromuscular symptoms or ECG changes reduction of potassium intake and correction of underlying abnormalities. In acute or severe hyperkalemia, plasma potassium greater than 6.5 to 7 millimole per liter, more urgent measures are to be taken. To stabilize cell membrane potential, infusion of calcium gluconate to stabilize conductive tissue membrane, to shift potassium into the cells, that is intravenous glucose and insulin, and intravenous sodium bicarbonate levels. To remove the excess potassium from the body, that is intravenous furosemide and normal saline. Ion exchange resin, example, disonium orally or rectally, and dialysis. So this was all about disorders of the potassium metabolism. This session was powered by Digital Version 2.0, JAYOTI VIDYAPEETH Women's University. I hope you are satisfied with my digital session. If you have any query, then please mention it in the comment box. I will try to resolve it. That was all for today. Thank you very much.